Good morning, everyone. Welcome to a special summer edition of Grand Rounds and this Global Oncology Seminar. Welcome also to our colleagues visiting online. It's my pleasure to introduce Dr. Ajay Aggarwal. Ajay's been a very good friend and close colleague for many years. He's a consultant clinical oncologist at Guy's and St. Thomas Hospital in the UK, where he focuses on the care of patients with urologic cancer. He is also an associate professor at the London School of Hygiene and Tropical Medicine. I got to know Ajay when we became roommates at the Credo Methods course that we teach in India. So we lived together in the same apartment every year for a week with our other friend, Richard Sullivan. One day there'll be a Netflix documentary about that experience. But in any case, Ajay is a thought leader in health services research, health systems policy planning, the value of cancer care, both from a radiotherapy and a systemic point of view. He also has very diverse interests when it comes to research with looking at things like value frameworks in radiotherapy, but he's also the PI on the Archery study, which is looking at deploying AI to help with radiotherapy planning in low and middle income countries globally. So I know that we're in for a treat today. Ajay's here for a couple of weeks as a visiting scientist at Cancer Care and Epidemiology, and he's enjoying the full Kingston experience with his children in Salem Camp. Welcome, Ajay.
Thank you.
To your lecture. Thanks.
Chris, thank you very much. Thanks, everyone, for attending. So how are we going to start this? We've got a complex problem, which is cancer. And one of the major factors in trying to solve that problem is through policy. And policy seeks to try and influence the cancer services we have, which ultimately try and influence the outcomes. So where do we start is with the outcomes, and we know there's a long way to go. So this is data from Europe. So this is looking over the common tumor types and the variation in 5-year survival across different countries. So if we look at the different cancers on the x-axis, we can see the poor survival down at the bottom, sadly, with esophageal, hepatocellular and pancreatic, and the better prognosis cancers such as testis and prostate. But if we take even something like prostate, even across Europe, we have this big difference in terms of survival between high and low. So the question that we all have, we're all been seeing policymakers, is how are we going to improve our outcome? What are we going to do? What do people say? We need more money. That's a big one. We need better treatments. We need more treatments. We need cutting edge treatments. Some increasingly with the pandemic, some discussion around workforce, but it's much more complex than that. So this is the health system. This is what I describe as the world that I'm currently living in. So if I'm a bit vague at times, it's because I'm suddenly on one side of this equation, but treatment's in the middle. But actually, if we're going to influence actually how we deliver care and outcomes, we have to deal with the system itself. But that's not necessarily conducive to policy. So we're talking things, everything from the political economy of cancer, health technology assessment, workforce, cancer service delivery, procurement pathway, service delivery. That is what influences outcomes. If you don't solve that puzzle, you're not necessarily going to improve outcomes per se, but it's very hard to do so. So if I'm a policymaker and someone sends me this slide, I'm going to say, well, give me 30 seconds of what we should do. And how we've derived things over the years is to look at policies to overcome that complexity to improve outcomes. What we need is good policy that will oversee what the system is requiring to actually improve it. And there are 3 policies that I want to talk about because they're germane to virtually every country in the world, and to show actually what do they deliver in terms of outcomes and equity, and where should we go in terms of trying to improve outcomes of cancer, because we do have a techno focus at the moment in terms of delivering outcomes, both from the provider perspective and also the patient perspective. Many of these you'll know. Centralization, command and control. You'll do what we say. These are the centers. We think these are the best centers. We're going to go from 50 centers to 20 centers, and actually that's going to drive performance. Or we say free market, we're libertarian. Let's put the power with the patients. Let the providers decide, actually, let's let the patient self-determine where they want the best care, how much they want to pay. Let the providers say, well, we're better than the competitor, and drive performance that way. Or we have a sort of third option, which is libertarian paternalism, which is around nudge. How can we create an incentive structure? This is commonly in public systems, which can allow patients to choose, give them that autonomy as to where they go for care, often with outcomes that are reported, and provide a nudge or a way of driving provider performance. And this is something that all countries are battling with it. We're seeing it, when people work, many of you here within policy, we're talking about how should we redesign services. So I want to talk about the actual truth behind many of these policies and what they actually try and deliver. Centralization is an obvious one to start. I think many of you are familiar with sort of the seminal work by Birkmayer in the late 90s, which essentially formed the actual evidence around centralization of surgery. We don't even think now to some degree about centralizing pancreatic surgery, esophageal cancer surgery. We know that it has a profound impact on mortality. But actually, we have this policy that's working, that's got evidence in those particular tumor types. But we know that across a lot of surgeries, whether it be prostate cancer, for instance, there's a lot of move towards centralization. But what really is the evidence behind that? We're changing the structure of our service to try and drive outcomes, but are we missing some elements which are going to make a difference? So I think if we look at the evidence deep down, because there's some people, the mantra, you do more, you're better at it. You do more, you're better at it. But do more of what? Is it the actual procedure? Is it the fact that your team is more skilled and better? Is it the fact that you've got more experience dealing with more complex cases? Is it applicable to all cancer types? We know that bowel cancer, breast cancer, they're high volume, so people are actually doing enough procedures already. But can we get better? Let's take bowel. Where does rectal cancer come into that? In the TME era. What do we define as low volume? Is there actually a cutoff? Oh, right, I've done 50, I'm going to be brilliant. Oh, I've done 48, I'm not so good. We really need to think about this, because actually these are policy pieces that put in the literature and said, you need to do this. If you don't do this, you'll shut down. What are the implications of centralization? There is that on the one hand, we want to improve outcomes, but people actually have to get to care. And I think you know that better than anyone here in Canada in terms of accessibility of care, both in terms of utilization, but we still struggle with the unmet need. How many people actually don't get to the doctor in the first place? How many people get to the doctor, get a diagnosis and decide, actually, I don't want to have a radical treatment, or I'm going to choose the treatment that's closer to me. So I'm going to show some of the behavioral elements from it. It's not just surgery, multimodality, systemic therapy. Should we be centralizing where IO chemotherapy, IO systemic therapy should be given, radiotherapy? And how do we decide which centers to close? So on the one hand, we have this literature, everyone loves it, it's in the New England Journal of Medicine, but then how do you actually operationalize that? No one gives you the recipe. So I'm just going to talk a bit more about that. And just that first instance, so this was just a piece of work, and I think one of the benefits we have in the NHS, we have these large centralized data sets for all patients treated within the public sector. So that's 90 to 95% of patients. And this was work looking at PROMs. And I think what I wanted to make the point was, we didn't see any volume outcome effect, but I think this is indicative of where we're at. When you look at the volume outcome literature, this is based predominantly from US data, where some centers are doing less than 5 procedures. It's absolutely going to be, a factor that if you do less than 5 procedures, you might not be very good at it. Most European health states or socialized health states actually have quite significant volumes compared to that literature. So actually, is this about eradicating low volume surgery as opposed to trying to find a threshold of volume outcome? And that makes sense as well, but it's a slightly different argument in terms of how we look at the centralization element. Then we actually say, well, do patients actually receive the treatment? So again, this is from the UK looking at prostate cancer. So surgery centralized to 50 centers, radiotherapies in 50 centers, not necessarily in the same hospital, only about 50% of them are in the same hospital. And there's also high dose rate brachytherapy, which many of you use in different centers, but that's only in 12 or 13 hospitals. And what we find is we have this system of hub and spoke. You are 25% less likely, even if you're eligible to get surgery, if you're not diagnosed at a center which offers surgery. I think that's quite a big thing, to be honest. Hub and spoke, oh yeah, we've got this great relationship with our hospital. We send patients all the time, but does that actually happen? The data suggests it doesn't always happen. High dose rate brachytherapy, it has its proponents, it has people who criticize it. You're 600% less likely to have it if you're not diagnosed in a network which offers it. Now, these might be small things, but we're talking about getting treatments and access to treatments. Actually, we're talking about access to an evidence-based treatment. And actually what's failing is probably the referral pattern, or whether patients maybe, or whether professionals have the system to refer people, or whether they lose income from referring patients to others. Don't forget that there's also incentives about keeping patients locally. Oh, well, we have a great treatment. It's, the robot is the robot, or our external beam radiotherapies with this fancy true beam machine. That's going to be better than the dose escalation you're going to get. So we have to see how this plays out. I thought this was actually quite sobering is the way I would describe it. So hepatic resection after colorectal cancer, we know it works. It's centralized, heavily centralized. There's 160 bowel cancer surgery units in the NHS, but about 30 or 40 hepatic resection units. If you're diagnosed in a place with liver mets with bowel cancer and it doesn't have a hepatic resection unit, you're less likely to get it. That seems obvious, but you're more likely to die. These are profound implications just from the design of the service, just because we don't have that pathway referral. And MDTs are great. Yes, we go around in a meeting, but there's still a gap that we're having. So this is the other side of centralization that we need to consider. Now, I've got deliberately a complex slide just to make everyone wake up, because we're now talking a bit about radiotherapy. And so this is a recent piece of work that we've done, which is a meta-analysis, and I'll guide you through this. But the obvious question is, well, actually, radiotherapy is getting more technical. Actually, is there a volume outcome relationship? So we appraised all the evidence and did a meta-analysis. And there's just two things to say. One is the summary conclusion, which is overall across different tumor types, there seemed to be an effect, particularly on mortality, for high volume centers, and improvement for radiotherapy volume. But that was particularly marked for nasopharyngeal cancer and head and neck cancers per se. But the data is not great, let's be honest, both in terms of case mix, use of other endpoints other than mortality. It was all lacking. But where does radiotherapy provision come into this? So we've talked about surgery, we've talked about radiotherapy, and actually we're centralizing radiotherapy, we're centralizing surgery. If you take something like prostate cancer, people have the option for both. And we know some haven't presented it, but actually patients are more likely to go for the one that's closer to them. So this design of the service impacts on what patients receive, or if they receive it at all, and then has an impact on outcomes. So we really need to pay attention to it. So the question is there a solution? I've just been going on about, oh, this is a problem and that's a problem and the evidence is not great. And is there a solution? So we tried to do this with this piece of modeling work, which took about 7 years to develop, just because of the data science requirements and the actual different methods that we were going to look at. And we wanted to ask the question, look, people are centralizing in every country in the world. How do you do it? How can we make a judgment call before we actually do it? Because I don't know if people have been in the meetings when they've talked about centralization. I mean, it's just very interesting. I think there was one on pediatric radiotherapy, and people going, oh, yeah, well, we need a center in London. Oh, yeah, we need a center in Birmingham. Oh, Bristol's a good center. And people were just talking about their brand. People were talking about their identity. People were talking about their population. And I think I put my hand up and said, how about equity? How about looking to see where people will travel to or how far? And it was just, people were consumed by this notion of how good they were and what they deserve and where that care should be and how they're offering the service, neither with any outcomes nor semblance of where the population is. And the classic example is we've centralized stroke units, and the stroke units are in great hospitals, UCL, Guy's and St Thomas's, St Mary's Hospital, but all the elderly people live in the outskirts, so they have to go into central London to actually access care. So the building of this models is based on that. And so what we wanted to do is, using actual data on patients receiving treatment, can we actually explore a modeling tool for any given case of scenario, tells you how many patients are going to be affected, how far on average will they have to travel further? Does that travel time disproportionately affect particular patient groups? The elderly, lower socioeconomic groups, particular ethnic groups. Does it impact on outcomes? Are their outcomes going to be worse from actually moving to a different center? And also looking at efficiency. Who's going to do all the extra work? Where's that extra work going to go? And so we wanted to explore this, and we use this on actually a rectal cancer data set on patients treated in 2018, so all patients. So it's about 12,000 patients, and we used data that was linked, which was our hospital administrative data, and different methods. So we had to map the patients geographically. We had to use econometric model methods in terms of the modeling. But the basic sense is we have roughly 12,000 patients in this time period, and they were treated at 163 centers. The key bit of this, though, is that the assumption is that people go to their nearest center. But what we know amongst patients with bowel or rectal cancer in particular is that about 1 in 5 or 1 in 4 go to a center other than their nearest. If you're younger, you're fitter, you're more affluent, you're more able to do that. So what this model takes into account is that when you close a center and it reallocates you, it doesn't just reallocate you to your nearest one, it also reallocates on the basis on your preferences, taking into account that some patients prefer a center with robotic surgery, or some patients prefer to have treatment in a comprehensive cancer center. Equally, the elderly are less likely to travel than older people. So we used a choice model based on willingness to travel. So it was 2 approaches, and we looked at the impact on equity and outcomes. So these were our scenarios that we chose, and this was just, and all the data we produced, the models are open source within the publication. But, this is the map of England. missing home, obviously. No. And then what we can see here is the different centers. So the blue and the yellow are all the combined are all the bowel cancer centers offering rectal cancer surgery in the NHS. So 163 of them. The yellow dots represent in these hypothetical scenarios which centers were closed. So if we look at A, shutting down low volume units, okay, those not doing 20 a year, that's reasonable. Second one, well, what about shutting all the centers that didn't have radiotherapy and surgery co-located? That would result in 118 centers being closed. Third one, what about shutting those centers where patients were already leaving to go to other centers, i.e. bypassing them? So that could have an effect. This last one was what do you do about, how about shutting those centers with the highest readmission rates? There were some centers with readmission rates of 30 or 40%. These are just pragmatic scenarios. You could maybe say to a policymaker, look, these things matter. Let's have a look at it. And you can look at combinations of factors. And what we're able to do from these trade-offs, and I won't go into the back end of it, is essentially produce a policy document which tells you from these different scenarios, A to E, how many centers would close, how many patients it would affect as a proportion, what's their travel time. And interestingly, we were talking about, scenario B, you shut 112 centers, scenario A, you shut 43 centers, and look at the actual additional travel time. It's not that much more different. And it's also because of the location. So a lot of these non-comprehensive cancer centers are already in dense urban environments where there's a lot of choice already. But actually the other side of the coin is, if you shut so many centers, there's going to be far more workload. And so you can estimate that with the model. And also looking at outcome, you can estimate that as well, which we're able to do. So here's something that pragmatically can be used. This is just using rectal cancer surgery as an example. It can be used for any tumor type, for any modality of care, but at least goes beyond the making it up, which we need to stamp out as of today, hopefully, if you've seen this and anyone's involved in these discussions. And this is something that we're integrating in the NHS in terms of a model for actually trying to approach this or have that discussion. Okay, so we've dealt with centralization. Let's go more behavioral public policy, so choice and competition. The person on the left is Julian Legrand. He's a professor at the London School of Economics. He's retired now. A huge thought leader in how we design our system. And he spoke very eloquently when I was there, this is 2012, about trust and mistrust models. So he was telling me the story in the early 90s that they had a trust model of the NHS. So give the money to the doctors will decide where it's spent because they know best, and we'll have a better, more equitable, more efficient health system. That failed. So people have tried that model before. As much as we hate to think, actually, as much as we think we know best in these matters and how to design things, we actually haven't been proven to be that good at it. Then in the late 90s and early 2000s, we went to this mistrust model, targets, hierarchy. We need to make sure people are seen within this many days. People coming as emergencies need to be seen within 4 hours. If you didn't meet those targets, directors of the hospitals were brought in and, given a full telling off. So it caused a lot of alarm, but it was effective, but it also crowded out a lot of goodwill. Suddenly people were up to performance measures and it didn't sit down well. So what he came up with Tony Blair in the 2000s was this notion of choice and competition. And it was around the time of nudge policies. And what he said was, well, look, why doesn't the nudge come from the patient? So the patient is a rational consumer. They know what's good for them. Let's give them information about the quality of care. We'll put it on this website, NHS Choices. They can look at their hospital. They can see what the hip revision rates are. They can make that choice. It's a publicly funded system. So the money follows the patient. And so hospitals don't compete on income. The hospitals aren't doing price competition, but they could lose income if patients then move. So he used the threat of loss of income as a driver for improving performance. So this is where the nudge came in. And it was a nudge because it wasn't expected that lots of people moved. It was more the threat. He was expecting empirically that 5 or 10% would move, and that would be driving performance. And this changed our policy. So in 2006, this came about. You could technically, within the NHS constitution, choose any provider that you want for particularly for surgery, various things. That's where it started off. And it was meant to be for cataracts, hernias, all the stuff where there can be waiting lists people use. But there was lots of information we didn't know. There was people looking at a competitive market for elective surgery and then saying, oh, look, in the most competitive markets, people have lower mortality from heart, from MI. How do those two equate? So the data wasn't great. There was also a question around equity, who was actually shopping around for treatment itself. What about efficiency in terms of uptake of technologies? So we went through this process for the last decade, and I was sitting there in the London School of Economics going, you're telling me that patient choice is equitable. Well, we know it isn't. And they said, well, everyone's got a free choice in this model because anyone can ask. And I said, yes, but the willingness to travel might be different, the propensity to also make those decisions. And also, they don't even have the outcomes that you're talking about. So actually, what are people going to make a decision on? So this got me thinking, and this is around 2013 or 14, and was the prelude to probably sort of the initial foray in policy-related work, which is I was seeing it differently. So I was a resident in London. And so London, sort of this vast urban state, lots of hospitals, and you would train and you would go on the tube, basically. You'd work in UCL, or you'd go to Guy's and St. Thomas's, or you'd go to, Imperial. And one thing I was noticing, and these are all 2 miles apart, is that they all had different radiotherapy machines. And I remember going, asking my bosses, you've got a cyber knife, they've got a true beam, why have you got a cyber knife and they've got a true beam? And no one could give me a straight answer. I said, well, is one better? Why have you all got different types of why have you got different types of kit? And I was like, no proper answer. Then I realized that actually in London as well, there's a big private sector. People were working in both sectors. And then there was also the brand reputation. Everything was about brand. We know about brands, the Royal Mazda and UCL, all these things. And I'm just thinking, hang on a minute. So there's choice and competition. And I've seen patients who are moving from different parts of the country, some of them, not many. Maybe something's going on, but it's not going in the way we're thinking. Maybe hospitals are setting themselves up in a different way to be seen as or perceived as high quality based on their brand, based on their reputation. How might they be doing that? And often these hospitals would have clinicians who are in the media or well known. Don't get me wrong, some extremely clever and competent people, but something wasn't right. So what we did in this piece of work, which actually a major piece of work from my PhD, was to ask the question in prostate cancer surgery, do people shop around for treatment? There has been no data in cancer, full stop. If people do shop around for treatment, what's their profile? Is it equitable or is it younger people? And if they are moving around, what's the impact on the hospitals? And what are the reasons why people might be moving around in the first place? So this was a piece of work published in the Lancet Oncology. And so we took 20,000 patients who had been treated for prostate cancer surgery between 2010 and 2014. And we mapped where the centers were, where they received treatment local to them, and who moved away. So what we found was initially, well, this is Norwich. The green dots are basically all the patients who had their prostate cancer surgery, who live near Norwich, who had their treatment in Norwich. Brilliant, thank you. Yeah, so 20,000 patients. We mapped where they lived, where they had treatment relative to where they lived. This is what everyone thought was happening. So when I applied for funding for this project, they said, oh yeah, interesting, but no one moves for treatment, we know that. Many people said that. And I said, well, let's just see. But, the first place you look at, Norwich, East Anglia, very rural, patients tend to go for local care. So the orange dots are patients who went elsewhere, and the red dots are people who had a different center closer who went to Norwich. This is what everyone thought was happening in the current health system. This is what was happening when you looked in other parts of the country. So if we take here Bristol, and over there Cambridge, the crosses are individual radical prostatectomy centers. So there were 65 at this time. The dots are individual patients. In this scenario, what we were looking at, the green dots are all the patients who lived close to Bristol who had their treatment there. The blue dots are all the patients who actually had other prostatectomy centers closer to them who decided to travel to Bristol for their treatment. So what's going on here? Huge numbers. Most of the numbers of patients having their treatment in Bristol from actually outside their area, coming from really far. Look at in Cambridge, people were coming from Southeast London, East Midlands, Essex, Norfolk. What was going on? This had never been seen before. This was just a hypothesis that maybe people might be moving around. And we found they weren't just moving around. It wasn't 5%. It was 1 in 3 men were moving to a center of the nearest. And from an equity perspective, these were younger, fitter, more affluent. So in terms of a choice and competition model, Why were they moving? Because we didn't have any prostatectomy outcomes at that time. And if they were moving and they did have better outcomes, then these men were potentially getting better outcomes because they were able to access that care. So we then asked the question, what was happening? And you can Google now, best prostate cancer surgeon in the UK, best breast cancer surgeon in the UK. This was at the time, this was the publication. There's one that was updated in 2020, but this is what they used. And you have this list of 12 surgeons in these hospitals. And you look at them and you've heard of them. You can't say you're a bad surgeon. What they were doing, they had, and this is in our major sort of tabloid paper as such, but the actual surgeons that were there were well known. Do you know if they have better outcomes? Well, no one knows. They didn't, because we weren't reporting outcomes at the time, but they were saying, oh, you know, they've got lots of publications, they're at the cutting edge, you know, they know their way around a robot. I mean, what does that mean exactly? But that is actually quite compelling in terms of how people behave. So we found that the centers that employed doctors who were on this list, and this was mentioned in qualitative interviews, this article, so it's not just come out of thin air, were actually more likely to receive patients. But the other factor is that actually if 1 in 3 patients are moving, you've got centers that are losing patients and other centers that are gaining patients. Okay, that's going to cause some degree of change. So actually the shift, so we've got these 65 centers, and these are centers doing more patients than were expected because people were coming out of area. And those are centers that are doing far less patients because they were losing patients from their catchment area. There's 2 factors. The ones that were gaining patients were all the early adopters of robotic surgery. So I'm talking about the mid-2000s, 2006, 2007. So they bought the technology, they asked their hospital to invest, or they asked charity sector to invest, and they started to use it. Those were the early adopters, and those patients were moving to those centers. Then you had other centers that were losing patients. But I've talked about policy. You've got centralization policy. We had centralization policy at this time. If you didn't do 50 pelvic surgeries a year, you could close down. They probably weren't even realizing that they were losing patients from their local catchment area. So what happened? Centers closed. So we went between 2010 and 2014 from 65 centers to sort of 57 centers. We're now at 50 centers. But what did the other centers do? What would you do? You're not doing enough volume. You're probably perceiving that there's some brand recognition. What would you do? You're at Queen's and you're seeing everyone's moving, and they're deciding they'd rather travel to Halifax to have their surgery. What would you do? And you realize that Halifax have a robot and you don't.
I'll tell you what we actually did.
Okay.
We bought a robot.
Yeah. So they all bought robots, and even irrespective of volume, none of them shut. None of them. So volume came out of the question because you can't close a robotics center. But then equally, you've got to survive, and I'll come into that in the next bit. So this was the quantitative component, but there was a qualitative component. It was actually really interesting, you know, speaking to patients, particularly in those areas in the southwest of England, because they were telling me that, you know, Da Vinci was setting up in their malls so that you could actually sit on the, you know, robot and play on the console. You know, the sort of marketing, the golf club discussions, all the things that you think might be happening was a reality. But also there was a real concern that actually there's so much information out there. How do you perceive what quality is? Why doesn't someone want to have the best care that's possible? You know, we've got this paternalistic attitude to information when people just want to know and have some transparency, or at least trust that the care they're going to get is good enough, because otherwise there's this perennial struggle of, oh, I had care locally because it was, you know, more convenient for me, but I don't know whether I would have had better care if I went to London. You know, these were the types of narratives that people had. From a provider perspective, they were very honest in the interviews. They said, look, if we don't get a robot, we'll lose our prostate cancer surgery practice. We could lose our esophageal cancer practice, our bowel cancer practice. There was a real existential threat. So choice and competition was working, but not necessarily in the way we wanted it to work, because we were missing that provider incentive. And then training came into it. Who wants to go to a center where you're not learning the newest technique? So there was a concern that people would lose their trainees. So lots of centers went. The most worrying thing, though, is this concept of, there's a great quote, of feeding the robot. It was from person who moved into diagnostic space, and he said, look, once you get it, to make it work, to make it run, you've got to feed it. So I think we've probably seen more high risk cases having prostatectomy, but then it doesn't just go for the prostate. Your rectal cancer surgeon, your head and neck cancer surgeon says, oh yeah, that's a really good piece of kit. I'm not saying that they're not that there might not be some advantage, although the randomized evidence is sketchy on that. But what I'm saying is it does have an impact, and we have both stage migration in terms of its utilization, and we also have change in terms of the actual professions that are using it within disciplines. So then the question is, though, in the UK, we went from 65 centres to 50 centres, and they all had robots. Has it made any difference to actual outcomes? So we actually report outcomes now, and this is severe urinary toxicity after radical surgery. So the dots are individual hospitals. The x-axis shows the volume at each of those hospitals, and the y-axis is the adjusted severe toxicity rate. And we can see there's huge variation in the actual robotics era. So rather than thinking, well, this is going to drive up the standard of care, which many thought, we've still got variation. And if we ask individuals, when we do, because we report this publicly, why are you doing worse, or why are you doing better? They already know. Surgeons are very good at auditing their results. Oh, well, we're using a different technique, or that surgeon doesn't work here anymore. So there are other elements of quality that can drive standards. The question is if that was available at the time, would we have seen something different, or would have robotics hold the key? I've purposely put in another complex slide just to wake people up. We're getting through this, but we have to go back to the original notion, because we've said that there was an incentive for providers to get robotics and then to continue to get robotics. We saw that patients were prepared to move, and with that market share. But the question is, does competition improve outcomes? And I said the evidence is slightly sketchy. And all this graphic shows is that the more competitive you get, and as you go to the far right, there's places like Manchester and London, and these are individual centres, is what we can see is that the gain or loss of patients was the greatest in the most competitive areas. It was also the areas where you were the early adopters of robotics, and it was also the areas where centres were more likely to close. So there's clearly a natural selection process, both in terms of early adoption. Question is, does that translate to better outcomes? So hospitals in that competitive area, do they have better outcomes? So we looked at it in prostate cancer, but I actually want to show you our results from looking at rectal cancer. So we had a similar profile, but many more centers, 160 centers. We could see that there was mobility of patients, and we published it in JAMA Surgery, a big driver towards robotic centers, particularly. And what we saw that actually in the most competitive areas, you were less likely, pound for pound, and we could adjust. We have very good data from our bowel cancer audit. You're less likely to have a permanent stoma forming procedure, AP resection, in the most competitive areas. So probably there's thoughts around more likely to be doing low anterior resections, for instance. You had a lower risk of 90-day readmission, and you were more likely, if you'd had a temporary stoma, I guess, to have that reversed at 18 months. So there is something going on, and there could be something to tap into. So I'm not averse to market models of care. I just think we've got the incentives completely wrong. So I don't think we should push it out completely, which then has taken my thinking to, well, actually is the missing link, both from a provider perspective and a patient perspective, reporting the outcomes in the first place. We have centralization, and we're not sure how we should do it, where we should do it, and if it improves outcomes. We have competition that requires people to act as consumers and providers to improve their outcomes. But we don't publish outcomes. Everyone talks about improving care, but so few health systems. We have money and we spend money, and yet we don't have a data science infrastructure to publish outcomes on a variety of endpoints: hard outcomes, mortality, survival, other outcomes, readmissions, toxicity rates, use of proms and prems. It is inexcusable. We have to really reflect. Chris, Bashar, many here are doing great work with common sense in oncology. There is no common sense in not having outcomes. Please, we just have to change that paradigm. And I'll tell you why. It resolves information asymmetry. A lot of what we see is because of perverse incentives, particularly on patients and having that information. But it is hard. That was my just rant, but it is hard because actually, first of all, what measures do you have? How do you get quality? Is there any point looking at 5-year survival if you're trying to improve outcomes of care now? They have to be within data such and relevant for that tumor type and that modality. Data is a big issue. Joined up infrastructure, what are you comparing? Are you comparing private, public, within region? How do you actually then benchmark? And if we do quality measurement, how do you then improve outcomes after that? So does it improve outcomes? Does the actual reporting do it? And so just in terms of the empirical or the conceptual basis for outcome reporting, the early studies looked outcomes across these centers. They did a trial. So we're going to give providers a letter. These are your outcomes. This is where you sit relative to everyone else. And then they looked to see what the improvement was. Or they also did an experiment where they publicly reported it. The public reporting had more effect in terms of improving outcomes because there was a reputational effect, whether we like it or not. There's an intrinsic motivation. I mean, Don Berwick wrote about this in the change selection pathway, but that's a factor. And then there's also the pecuniary factor in terms of patient movement, loss of income. So we're not quite sure how it works specifically, but there are huge benefits, which I'm going to come into in my closing slides, which is benchmarking, knowing what other people are up to, knowing what people do. We live in silos, and those silos are brought out from, oh, I was at medical school at a place, and this seemed really good, and everyone seemed really educated, and they seem to be at the cutting edge. But you never know what someone else is doing. And if they're not doing what you're doing, you look at them with suspicion. And I think radiotherapy is a good example. You know, there are people who love brachytherapy. There are people who love HDR. There are people who love SBRT. There are people who love seed. You know, it's just endless where we go. But actually, no one can say, well, what is the best? Because A, we don't do the comparative measures, but equally, it's silos of care. It's we know best. So I think benchmarking is really important, and it also allows the opportunity to look at your own outcomes. Oh, actually, we didn't do as good as we thought. What's going on? Maybe we should look. That reflection is critical, and it could have wider implications from a value perspective in terms of the diminishing the impact of technology. So in the NHS, we have 10 cancer audits now. We started off with 5 actually, which was lung, prostate, breast, esophageal cancer, and bowel. We've got another 5, which has started this year, and up in pancreatic, ovarian, and it includes all patients treated in the NHS. It's not just structural factors, how many machines they have, what facilities they have, but also more and more outcomes. So 12-month mortality rates, readmission rates, particularly for surgery, and we're moving more and more to toxicity and blended outcomes. So does it improve outcomes? So this is one of the few studies that have been doing in cancer care. So this was looking at patients, proportion of patients, 90-day mortality rates across hospitals. And this was public reporting of surgical outcomes. And what we could see from the onset of the audit and the public reporting, there was a decrease, and that was adjusted for things like gaming and cream skimming, whatever you call it, i.e. patients taking, surgeons selecting particular patients. So that's some of the early evidence that actually there was a reduction in mortality rates. The question is, what do we know about other diseases? So the surgeons, as I said, started this all in the early 90s. Cardiac surgery, there's a lot of stuff in hips and knees, more and more for cancer surgery and thoracic surgery in particular. But what we launched, and it took 3-4 years to develop, was a public reporting program for radiotherapy after prostate cancer. So we were looking at, you know, survival's not going to be helpful because by the time you get meaningful survival differences, technology's moved on, practices moved on. So one of the key things we know within radiotherapy is to try and reduce toxicity. All the studies are looking at maybe equivalent or reduction in toxicity. And so we reported that variation in toxicity rates across hospitals in the NHS. So there were 50 radiotherapy centers. We used 2 things. We used indicators that we developed in a data science approach using linked data sets, cancer registry, hospital episodes to actually work out if people were getting grade 2 or 3 toxicity. We also did a national PROMS program, and we got a 70% response rate. So these were patients who'd had radiotherapy and responded to a questionnaire or a survey, which we were also able to link in at the hospital level. This was fully adjusted, stage, age, socioeconomic status, but it wasn't necessarily adjusted for why the variation might be, i.e. IMRT, because that's one of the factors that you'd want to look at or reflect on in benchmarking. So what we found, and this was quite a surprise, was that even in the IMRT era, there was quite a significant variation in GI toxicity rates. If you measure it, you find the truth. So there was a variation between 2% and 25%. So let me just break this down. These are individual hospitals. These are the volume of patients, and this is the percentage grade 2 or above GI toxicity rates. These are funnel plots. So the dark red line above that, your 3 standard deviations from the average. So most people are around the average, which is 10%. So it's not about trying to find necessarily rank you. But what we have here is we have high performers, so in the green dots, and we have those that are not performing as well. So before this comes out publicly, and patients can look on our portal for an individual hospital, we ask those centers to look at their own data and to validate that data with their own internal audit, because we don't ask people to push handwritten data. They found that those rates were correct. And there were some big hospitals. My hospital on the second year of this was here. So, you know, you build a gun, you have to realize that you can point it at yourself. And it's not pleasant because we didn't have a culture for it. You suddenly say, oh, look, there's, you know, Ajay's doing great work with the audit, he's developed this thing. And then you then have to say, well, actually, we're not doing so good. That wasn't pleasant. And it wasn't that people were doing anything wrong, but people are not. In radiation oncology as a field, we think we're good at quality assurance, but we don't often know what our outcome is to then feed back in our process of care. We did an internal audit, predominantly to try and see whether it was the truth or not, but they found the same. I think I remember the email. You know, the audit said there was 16% rate of toxicity. We've done our internal audit. Yeah, it's 17%. It was one of those moments, but actually it was the catalyst for change. And what we did is we asked what the recipe was in that green dot. So we benchmarked, and it wasn't about, they weren't doing any AI, they weren't using rectal spacers, they weren't using protons, they weren't using the MRI LINAC. What I found is the key ingredient and something as a take-home message about where we started off: policy, trying to improve outcomes, but maintaining equity. Maybe we don't need to shut centers, but we need to report outcomes. Transparency was, you know, Banana Rama had it right all along. It's not what you do, it's the way that you do it. And what it showed is that marginal gains philosophy about the meticulousness of what we do day to day. What they were doing was moving that Clatterbridge Center, Isabel Syndicus, was just moving the bar forward bit by bit by bit by bit. It highlighted team performance. All of these things are free of charge. Peer review processes, contouring protocols, reducing your margins. I mean, they're quite technical radiotherapy things. I know not everyone hears from a rad-onc field, but the point I'm trying to say is that these don't necessarily need to buy in an expensive piece of kit. This is stuff that we then integrated within 6 months. We weren't doing anything wrong. We were just following previous trial protocols. But the point is that when you measure it and you compare, people are always moving moving processes along in the same way technology does, but practices of care. And we were able to integrate that, and it's had a substantial impact, both in terms of us as a department from communication and the way we work together, but also constantly seeing how we can reflect and audit our results. So final slide. I think fact is many of our fundamental policies lack a strong evidence base. So we need to see how we translate them into our own health systems. That requires good empirical research, good data, mixed methods. We need to collaborate. So I showed some of the work that I've been doing, you know, epidemiologists, econometricians, social science researchers. We need to be multidisciplinary as well to deal with the many facets of healthcare, to be able to try and get closer to the answer, because otherwise we'll try and find a simplistic solution. I think outcome reporting is a real critical element of what we do, and we need to engage with policy at the beginning. And I was very lucky that a lot of this work was funded by our equivalent of CIHR, the NIHR. Yeah, happy to talk more on this topic. You can see that it's something that I've thought about, just want to thank both my collaborators and also Chris for inviting me. It's always great to make great friendships along the way, and it's truly been one of those. So thanks everyone for your hospitality and your attention. Thank you.
Thank you, Ajay. It was a brilliant lecture, lots of food for thought, especially there's parallels obviously between the NHS and the Canadian health system about how we can drive change. Just opening the floor for questions, comments, and Daniel, maybe can you keep an eye on the chat and Zoom. Andrew.
Thank you. Andrew Ramos, I'm an oncologist here. Just a couple of quick questions. In your centralization, one of the things in Ontario when we centralized, we kept like some thoracic surgery centers that were below volume because for effect on other things like trauma that's not related to cancer. And I wonder if the same sort of things happen in the NHS with centralization. Like it's fine to centralize rectal surgery, but you need to have enough general surgeons for when your appendicitis comes in, etc. And if there's any look at those. I guess the second question is in terms of measuring, you said measuring toxicity outcomes of 17% and so on. Are these hard enough outcomes? Like we know in trials that, you know, because in hotel we're good at endpoints that matter, so survival and so on, but things like toxicity, like are some centers just more diligent in, you know, calling a diarrhea a treatment-related diarrhea versus a other diarrhea?
Yeah, so I'll take both those points. I think the first point you made is probably one of the challenges for centralizing rectal cancer surgery. Absolutely. What happens with the urgent case? What happens with the obstruction? So you need to have some bowel cancer surgeons on board. So I think probably you'd have to centralize both together. But then you also make another good point, which is around urgent care. And so there's another question around who should be performing those urgent operations when they come. Is it better for patients to travel further to a hospital that's a recognized unit, whether you're doing out of hours and the actual technique? So I think that is a debate that's being played out. I think second of all, for radiotherapy especially, you look at in prostate cancer, toxicity is an absolutely fundamental endpoint. And the factor when in terms of how we developed it was actually not, you know, in a trial, what happens? A patient comes in, you fill in the form, your resident or a fellow will look at it, or you yourself, and you'll make a classification. That's what happened. This was based on both procedures and actual diagnostic code. So there was a hard endpoint in terms of how we actually developed the measure of that toxicity. The other factor is that we're not giving us a raw percentage. You mentioned the 17%. The point I was trying to make was we were an outlier. So there will be some wiggle room, you know, how you're grading X, Y, Z. But at the end of the day, if someone's bleeding or got severe toxicity, you're going to send them for a colonoscopy or a sigmoidoscopy. You're not going to go, oh, well, actually, you know, I know that they don't have this problem within 2 years of radiotherapy. You're then also on top of that, they would have had to have had a code for that toxicity. So it wasn't just grade 1 or a bit of diarrhea. But the point that I'm making is that we were looking for outlying performance. So you're looking for those that are significantly worse or better than the average, both with the better for the benchmarking and worse to then look at it. But interestingly, some of the other centers have looked into their own practice of care. So some people come back and say, oh, you know, we had higher rates of bleeding because we've got lots of people with warfarin in our area. What do you respond? You say, well, actually, there's not going to be a systematic difference in your area having more people on warfarin over and above an adjustment for age, for instance. You know, so those are the other factors that you have to consider. No, exactly. And then the other thing, and there was the same coding framework. And interestingly, when we did the PROMS program, the centers that had the worst outcomes on our coding related outcome also had the worst bowel function on the PROMS. So if you ask patients, they'll tell you as well.
Great. Michael.
Hey, a practical implementation question for you.
Yeah.
Internal audit.
Yeah.
So your phrase that it's inexcusable not to report outcomes. The things we can implement are free. Well, all the things that we're hearing is that we're burnt out after COVID. We don't have time. For example, peer review takes time. I could see that audit that you list, or the paper you listed there, lights a fire on everybody to produce an internal audit to either contradict or validate those outcomes. Can you speak to if there's an efficient way to do that that wouldn't kind of exacerbate our existing concerns on our time?
So I'd frame it differently. So this is not meant to be an adversarial approach to, you know, the carrot or the stick. I think we have a failure that even when we're training, we're not learning enough about quality management. Who within our department is the performance champion? This is about, there are plenty of people who will say on Journal Club, oh, this technology is really good, or they'll be great for doing their internal work, sort of like audit, on saying, oh, well, we've got this case series of 85 patients who were treated with SBRT fiducials, and we put a wig on them at the same time. So people are already doing it, but they don't see the value in this. So I would say three things, in fact. So one is we need to create the culture of it. I think there is time. Second, we need to generate performance champions. So there needs to be leadership. So you're absolutely right. It shouldn't necessarily and that generates the momentum of people looking out for these gains. And third of all, what I meant in terms of the cost of this is that actually we've got health systems that are spending hundreds of millions on our cancer care. And actually relative to this, I mean, even just setting up an audit is a fraction of maybe even one patient's cost of treatment over 4 or 5 years. So it's more that there's the top-down element, and then internally, I just think it's more of a cultural change that we need to derive.
Great. Tara.
Thank you. That was really eye-opening. And in Ontario, I don't know if you're aware of the details about our system, but we have a lot of data. But it's been quite siloed. There's been wait times where it's referral to consult to treatment. And then outcome data. And what we're realizing is it's really the transitions of care where the issues are happening, and that looking at one part is helpful, but really it's the spectrum that matters to the patient. So we are changing some of our outcomes to look at, for instance, with non-Hodgkin's lymphoma, the data biopsy to initiation with aggressive lymphoma, to look at a whole system approach. And I'm just wondering if anything like that has been done in other systems that you're aware of.
So the data biopsy to receipt, so the sort of the pathway. Yeah. So there is looked at the pathway. A huge amount actually looked at the pathway, and it's probably the one outcome that the NHS has spent a lot of time looking at. So we have these targets. We're not sure where the targets came from. I mean, the work that I did, Tim led, that we were doing in terms of waiting time and outcome, but we do focus on it, but we're not very good at working out how much it matters, if it does matter, where the gains in that pathway can be made. Because, I think there's pathways that are very good for people in centers that have I think lungs are a good example, because sometimes people need e-buses, mediastinoscopies, things like that. And often the peripheral hospitals who diagnose on a chest X-ray and CT and maybe do some bronchoscopy have to send in. So that is one element where a pathway is going to not do well. We have another element where the pathway, which as well as the efficiency of the care internally that we don't see, is that interestingly, the centers which were most popular with patients actually had the worst waiting times, because they're going for other aspects of quality. There's big wait times in many of these big hospitals because they're perceived to have better quality. So people think, well, actually, I'd rather ask my primary care physician to send me there because I think I'm going to get better quality care. So there's a perversion thinking alone that patients want quicker treatment. They do, but they want to have an assurance that they're having good treatment as well. And I think that's where outcomes can come in. So sorry, long answer, but yes, we are looking at it. B, have we found good solutions to the issue of the pathway? No, because I think it's multifactorial. It's internal processes, communication between referring sites and the actual centralized bit, and the fact that patients are also selecting on the basis of quality.
Great. I do have a question, and then Elizabeth, your data about outcomes, quality, and performance is obviously focusing on surgery and radiotherapy. There's a notable absence of systemic.
Yeah,
I would assume that's because the medical oncologists are outstanding and doing a wonderful job, or is there work to be done in that space?
Yeah. So Chris is a good plug. Obviously, we work together on precisely that. So within the bowel cancer audit, we painstakingly, I feel sorry for the PhD student, but she's still alive. She's doing good. She passed, but basically using all the coding from ICD-10 codes and various things and admissions, was able to map CTCAE criteria using the data set, so we could govern patients having grade 3 or above toxicity. We then use that to look at variation in patients having grade 3 toxicity for those having adjuvant chemotherapy for stage 3 bowel cancer, and also first line treatment for stage 4. And it was great having Chris's input in the paper. I'll send it round. I should have put it up given the audience, but we found that there was a big variation. There were 12 outliers. So for first of all, for stage 4 bowel cancer, the average rate of grade 3 toxicity requiring admission was 40%, 45%. The variation between centers was between 20 and 70%. So I think we have a huge amount to go in terms of looking at quality assurance for medical oncology as well, and particularly in the IO era. And I can send that round, that publication, and that's going to be publicly reported from next year.
The variation was so large that the Canadian co-investigator didn't believe it. I think the PhD student go back and decode it, but it was very large, very large. Elizabeth.
So many years ago, when there was the first Canadian strategy for cancer control, the federal government here created an agency called the Canadian Partnership Against Cancer to implement the strategy. And one of the first things it did, being led by the scientific directors and epidemiologists, was actually to do a system performance report, benchmarking provinces against each other on a few metrics that were the least threatening. So what was the uptake of cervical cancer screening in the target age, for example, by province? Could we learn something from the high uptake provinces that about their strategy of reaching people that the low intake ones could do? The initial report was anonymized, so you only knew you didn't know anyone else. But it was really well received, and around those tables, the cancer agencies, and most, but not all provinces have cancer agencies, used those data to improve processes around, especially screening programs and other things such as that. At the same time, I think it was Mike Richards was the cancer czar in the UK. There was concern about what was happening to comparatively the outcomes measured in England versus the rest of the world, and an international cancer benchmarking project was set up. I'm not sure if you're familiar with that.
Yeah, no, I am. Yeah.
Because it really tried to dissect why were outcomes so different in countries that more or less had public systems, that more or less invested the same amount. And I'm not sure it ever really nailed it down. But some of the variables, such as just looking at your prostate survival data related to things like if you decide you're going to do 100% screening of all men, your survival rate of prostate cancer is
91%. Yeah.
And if you only diagnose them opportunistically, that you will. Just some interesting anecdotes that people have tried to do this. Data is a problem, but also there tends to be a focus on looking at what is easy to measure, as opposed to necessarily taking the time to look at what is meaningful to measure. And I think that's kind of getting at some of what you were saying. It's hard work to look at what is meaningful. But it was an interesting story, and people do tend, even if they don't believe their own data, to really get galvanized by it. And the final anecdote is that we here in Ontario get 5-year relative survival for diagnoses of common tumors. A few years ago, our region had the lowest 5-year relative survival in lung cancer of the whole province of Ontario. We also have, paradoxically, the highest smoking rate, probably also the highest rates of smoking-related cancers. But it led to a series of projects that really helped us untangle what was mitigatable in the data and how we could behave differently.
Yeah, no, those are fantastic anecdotes. And I think you're right in terms of that inversion in terms of smoking rate also points to probably a greater comorbidity, income differentials, the social determinants of care. The ICBP is still going. They produced a policy report in Lancet Oncology earlier this year by my colleague Ellen Nolte, and that was looking at, they were trying to frame it around leadership and the pathway between leadership, policy, and then having clinical leaders to actually implement it. I think they found that there was a difference in that element as well as the social determinants. I think you're absolutely right. You need things that you can measure and are relevant. I was astonished by how much response we got from patients, 70% response rate. And actually that I think we need to involve patients more in terms of their perceptions and experience of care, which I think is also important.
Great.
But thank you.
Thanks, Ajay. There's one question, Chuck. I think we're gonna have to wrap up. Maybe we can respond to that offline, but thank you for an amazing lecture. I think one of the key points is we need to invest in this and make this is important. I mean, Ontario is going to spend $1.5 billion this year on cancer medicines, and only a sliver fraction into measuring how those medicines are being delivered, the quality and the return on the societal investment. So, and the same story I'm sure applies to radiotherapy and surgery. So we need to champion this. Thanks for all the work you do in this and for today. Great lecture.
Thanks. Thank you.